Thank you guys so much for tuning in. Today we have the special pleasure of Dr. Tanya Hoke joining us. She's a urogynecologist. So Tanya, thank you first of all for joining us.
Absolutely. Happy to be here.
Yeah. First question is, which came first for you? Like, was it the understanding that there was a massive need in women's health in this area, or was it you choosing to specialize this? And then once you specialized in it, it declared itself?
It was more of me picking the specialty first. I love surgery. I love having a long-term relationship with patients. And so this field kind of lended itself to both of those really nicely. And then when my husband and I were looking for areas that we both could practice in, we found that Florida really lended itself well to having, EM positions available and also a huge need for urogynecology. So this ended up being a perfect match down here.
So you specialized in GYN, and then what was the decision like to do urogyne focus?
So I always, in medical school, I wanted to be a urologist. And when I did those rotations and I compared it to OB/GYN, I felt that GYN was more my vibe, but I still love the urinary tract. I love the smaller, cystoscopic procedures. And when I did my residency in OB/GYN, as an intern, they let us rotate through all the fellowships, which is amazing because then you can set yourself up if you want to end up doing one of those. And so in October, I'll never forget, October of my intern year, I rotated on urogynecology, and I'm like, this is it. This is pairing that urology with GYN, and I never looked back.
Oh, that's awesome. That's awesome. So a lot of the people who are listening will be not doctors or medically trained. Can you kind of walk through what a urogynecologist does and how that's different or similar to what a urologist does?
Absolutely. So a urogynecologist pairs GYN with urology in the sense that we treat pelvic floor disorders in women. So a lot of my practice is made up of pelvic organ prolapse, where something is dropped in the vagina. We do a lot of incontinence, both stress incontinence, urge incontinence, recurrent UTIs. Urologists also do stones and cancer, which I do not. So I kind of limit to more benign conditions of the pelvic floor.
Okay, that's really helpful. So, and I guess also just to be super clear, when we say benign conditions, we mean
non-cancer.
Anything's non-cancer. Okay. And if a woman has a UTI or pelvic or a prolapse, like you mentioned, can she go to either a urogynecologist or a urologist?
A urologist, when they go to a residency program, their programs can be slanted towards cancer, stones, various different subspecialties within the practice of urology. It's very few programs that have a robust pelvic floor, or they call it female urology program. And so not many urologists in the United States focus on pelvic floor disorders in women because they didn't get a lot of that training. And so urogynecology is a fellowship training after residency for both urology and OB/GYN, where you can get that specialized training in that field. And so if a regular like urologist who's just came out of residency is out practicing, they may not focus on that field.
You were saying that the urologist may or may not get some exposure to this in residency, but the urogynecologist has this as a dedicated fellowship. So kind of like this is what you see all day, every day. Is that fair to say?
That is all I do. I don't do any routine pap smears or, GYN annuals. I just do pelvic floor dysfunction.
When was it that you started noticing that this was a very unmet need for women?
When I got out of training, because in training, you're at big academic centers. Everyone comes to your university or health system because they're the specialty and everything. And so I didn't really see what the real world was like until I graduated fellowship and went out into the world and started having a wait list that was crazy and not really realizing why. And then you start to, urogyne's a small field. You kind of find your people in the community, and there aren't really any out here. There's a few, down south, like near Boca. There's a few in Miami, but not a lot in West Palm Beach, and then even less, between here and Orlando. And so the group that I'm part of, it's a large OBGYN group that has, high risk OB, has OBGYN and Urogyne. They strategically placed me in areas, me specifically in an area that had a need, and then my other two partners in other areas. So we're not competing for patients, but really fulfilling this a need in our specific locations.
I find that there's awareness among just the general women who you interact with, or do you think that it really has to be identified by a doctor upstream who then tells them, hey, a urogynecologist is really might be able to help you with this?
If you asked me that 5 years ago, I would have said a physician or someone, a sister, a mother, or somebody had to tell the patient, like, hey, this is treatable. Yeah. Nowadays, with Facebook and more advertisements, patients are becoming much more, I think, health literate, and they're much more aware of different treatments and different problems. And also, women have a long history of being told to deal with whatever they're dealing with, that everything's fine, no big deal, just you take care of your family. And now women are more empowered to take care of themselves and, make sure that they are up to, date on their health, and that they're coming in more and they're taking care of themselves more. Yeah. And so I think it's a two-part, thing, and women are talking to other women, and it's really cool. I'll get one patient out of a friend group, and then they'll get treatment through me, whether it's surgery or medical management. And then they're like the guinea pig. And so they'll go back to their friend group, and then all of a sudden I get the rest of them. It's cool. And so word of mouth is huge. Women are now talking to women about these problems. Our mothers had these issues, and oh my goodness, if they ever said something about it to their daughters or their friends, it would be, unpolite. But now we're more educated, and it's wonderful.
You were saying like our moms wouldn't talk about this kind of stuff.
Right.
What do you think is the most taboo of the things that you deal with that people weren't talking about back then, that, we can treat, we can do something about, there should be a medical discussion moving forward?
I think definitely incontinence of both varieties, both urinary, and the most taboo is fecal incontinence, accidents of the bowels. Find that most ladies still don't talk about the accidents of the bowels because that's the most embarrassing. But urine leakage or urinary incontinence used to really not be a thing. You were wearing a little liner or a little pad and no one knew. But now a lot of ladies are talking about it, and especially, moms who want to go to the trampoline park with their kids. How many of those popped up in the last 10 years? And then now they're not jumping anymore because they leak when they jump. And so girlfriends are now talking about it, saying, hey, there's a treatment for that. Go see your friendly urogynecologist. And they come in. It's, very simple, non-surgical or surgical options. And we usually find something that works for everyone. There's an option for everyone, and it's not always the same.
Okay, cool.
Talk to my patients. I give a buffet of treatment options because everyone likes something different at a buffet. And so we kind of lay everything out, and they pick what works best for them and their lifestyle.
Okay, interesting. I don't really know the numbers around the prevalence. How common is it, urinary incontinence among women?
So by the time you reach the age of 80, 50% of women will have some pelvic floor dysfunction, whether it's pelvic organ prolapse or incontinence. So it's very common. And you see all the commercials on TV about gotta go right now. Everyone sees these commercials. The pad aisle at the grocery store is an entire aisle.
Right.
So it's super common, and it's very treatable. You don't have to live with it. I usually tell patients, common doesn't mean normal. So I try to get rid of the word normal. It's not normal to leak. It's common, just like diabetes is common, but it's not normal. It's treatable. Right. And so they don't have to keep living with these conditions.
Right. Can you lay out the spectrum, the menu on the buffet a little bit?
Sure. So for incontinence, we'll talk about urinary incontinence. It's more common than the bowels. There are the non-surgical options are pelvic floor physical therapy. So it's a female physical therapist who has extra training in pelvic floor in a private room. They do internal, vaginal manipulation to help you strengthen your pelvic floor. So I call it like Kegel boot camp. And so that's an option. There are pessaries. It's a little ring you place inside the vagina, and it helps support the urethra. That's what the stress incontinence is, from a weakness of the urethra. And so this little pessary, this little ring that you can remove on your own, can be placed inside and help give you that support. And then the surgical option, we have two. There's bulking of the urethra. It's a little like lip filler. People put lip filler in to kind of bulk it up. You could put filler into the urethra to help bulk that up and give it more support. Or a sling procedure, which is a mesh-based procedure that's very safe. You know, there's nothing like the lawsuits you see on TV about mesh or something different. Slings are probably the most common procedure I do on a weekly basis.
Mm. And what is the spectrum of for people who have urinary incontinence? How many will it be resolved like non-surgically versus people who end up needing surgery?
So being better and resolved are two different things. So in all of those treatment options, you will improve. The most effective is a sling procedure. 95% of my patients are dry from that procedure.
What is it? How is dry defined?
Dry, not leaking. So no urine coming out when you don't want it to.
Okay, ever. Okay.
I mean, sure, from that type of leakage. So there's overactive bladder type leakage. That's the urgency, frequency, gotta go, can't quite make it there. Different than the coughing, sneezing, laughing leakage, which is the stress incontinence.
Got it. Okay. And does pelvic floor exercise help with both or just the...
It does. Pelvic floor PT really should be mainstream. I think that's also gaining in popularity where these health systems didn't have physical therapists and you had to go and pay out of pocket for these private practices. And now more health systems are employing pelvic floor physical therapists as part of their PT, like rehab department. And it works wonders. You know, women who are after childbirth, I definitely recommend pelvic floor PT. Anyone really who has any weakness, just whether it's incontinence, prolapse, or you can have pelvic floor pain from a variety of different, you know, muscle conditions, pelvic floor PT is the way to go. And so, you know, it's a great treatment option for women that's not really invasive. There's no surgery, there's no medications, no side effects. It's great.
It's basically all upside. Yeah.
Yeah.
How would you know if you're weak other than if you're having the, you know, final, like the outcome of leaking? Is there a way before that to know?
So if you go and do your pelvic exam with your OB/GYN annually, you can ask about your muscle strength. You know, we recommend patients doing Kegel squeezes, and you can ask your OB/GYN during your pelvic exam if your Kegel squeeze is strong, because it's hard to know yourself if you're doing it right. A lot of people will squeeze their butt cheeks or their thighs or like suck in their abdomen. That's not your pelvic floor, like vaginal muscles. And so having someone give you that biofeedback is important. So your OB/GYN can do that. Or if you get a pelvic exam through your primary care, they do pap smears and annuals as well.
So all GYNs who can do a annual GYN exam also would be able to check for your strength?
Yeah, they can assess your Kegel squeeze for sure.
Are there any other symptoms that people would have that could clue them that they should do more pelvic floor PT, or they should think about that?
I'm not too sure if there's any other symptoms that they would recognize other than incontinence, prolapse, you know, bowel issues. Sometimes pelvic floor pain can lend itself towards PT, and they don't realize that they hold tension in their pelvic floor. And so they think it's, you know, abdominal pain or, you know, bladder issues, when really it's the pelvic floor muscles.
And the people who do the pelvic floor PT, how long are they usually with that in a program?
So it's usually hour-long sessions for 12 weeks or whenever you finish your treatment goal. But they do a full assessment like each time, and then they always send back records to whoever referred, so I'm in the loop as well. And once you finish your 12-week treatment plan, you can do maintenance, you can come back as needed. They generally leave the door open to help.
And basically, they should be specially trained in pelvic PT. You should make sure that before you go see them.
Yes, exactly, because not all PT is the same, and it does require special training for the pelvic floor muscles. Not every PT program generally gives that instruction.
Makes sense. Makes sense. And then, you know, you mentioned after childbirth, are there any other kind of like, you know, life stages or things that can happen to women that increases their likelihood of having urinary incontinence?
Absolutely. So having a hysterectomy for other conditions like fibroids, abnormal bleeding, those kind of things can increase your risk for prolapse and incontinence. And doing PT after a hysterectomy can be helpful.
Okay, so we talked a little bit about about pelvic floor prolapse and urinary incontinence. What else do you think people are, uncomfortable talking about that you deal with and see and wish, more light was shed on?
Probably pelvic floor pain. That is a big one because no one wants to deal with it. Pain patients are miserable. They're in pain every day. It sucks. And when they see a provider, they just kind of get thrown medications and then they say, okay, come back in 6 weeks or 3 months or whatever. And they kind of get pushed aside. And so seeing a pelvic floor specialist who can do that assessment for pelvic floor pain like I do, I think is super important. I see patients all the time who say it took them years to figure out to come to see me. And then we diagnose their pelvic floor muscle spasm. We give them treatment, whether it's medications or targeted injections or physical therapy. And their world has changed. It's amazing, but you have to get to someone who knows how to identify it. And and when someone's in pain, they're not going to tell their girlfriends like, hey, like everything hurts down there. They don't generally talk about it a lot.
And like you said, people might not know if it's kind of down there, but they don't know exactly where down there, where able to localize it.
Right.
It's amazing, actually. At first, I was thinking your job is on this overlap of this like gray zone part of medical territory between urology and gynecology. But it's also, in this gray zone place with pain management.
Yeah.
And then I'm assuming
because we do fecal incontinence.
I was going to say that exactly.
Yep. So I hang out with urologists, GI docs, pelvic floor PTs, even there's some pelvic pain specialists in my region who do like targeted therapy. And so we all kind of have each other's number. We all refer to each other and, help each other out where we can.
That's really cool. And I feel like that's a lesson in its own right for anyone who's listening to this, that if you are hitting a wall with your specialist, that specialist should be really happy to refer you to the other experts who overlap in kind of that problem. And usually that is the case. Whenever we come up as doctors, the end of our understanding, we usually know, who are some of the people who would be like, able to push that frontier a little bit further. So
absolutely.
It's awesome that you guys have such a like collegial collaborative environment.
No, I love it. It's fun. And my favorite part of this job is having patients come in who have these problems, finding a treatment plan that works best for them, going through that treatment plan, coming out the other side improved and happy. And now they're able to do the things they weren't able to, whether it's jump on the trampoline with their kids or, patients who couldn't go out with that lunch, date with their girlfriends because they leak and they don't, they're nervous about someone smelling something. Mm-hmm. Having them be able to get back to their quality of life is what makes me so happy to do my job.
Yeah. And the amount of urine that we're talking about is what?
It could be anywhere from a few drops to like going through diapers, multiple diapers per day.
Wow.
It's incredible because some ladies, their bladder just squeezes when it wants to, and it's a full void every time. And so they just can't get to the bathroom. And these are the ladies who don't leave their house. And that's, a huge, quality of life issue for these women.
Yeah.
And so having them have the knowledge to know this is treatable. And when their incontinence is so bad, we may not make them, again, dry. So not using pads, but much more manageable where they feel they can go out again and be back in society, go out with their friends.
Yeah. Yeah. Are there any new frontier developments in urogynecology that you think people should know about or should be thinking about? Or if they see a GYN or a urogynecologist, this would be like something for them to tip off that, oh, they're not, there's an alternative or there's something else to consider if they've been told no?
In terms of incontinence, there are medications that have been around for 50 years or so that have some pretty intense side effects like dry mouth, dry eye, constipation, even a risk of dementia over time.
Are these anticholinergics or?
Exactly. So anticholinergics have those side effects, but there are newer medications on the market that do not have any of those side effects. It's a completely different class. And so when I discuss,
so they work a different way, different mechanism of action. Okay.
Yes. And so when I discuss with patients starting a medication, they're like, oh, no, I don't want to have any of those side effects. I'm like, oh, no, there's more. There's a whole nother type of medication with a different mechanism of action to help not have those side effects, but are, equally, if not more effective for their incontinence. So those new medications have come out. There are some different types of treatments for incontinence in the sense of nerve stimulation. There's a cool thing where we can put a little acupuncture needle in the ankle called posterior tibial nerve stimulation. You kind of hook up a TENS unit to a little acupuncture needle in the ankle, and it stimulates a nerve that travels to your bladder. That's been around for a while, but there are new options such as an implantable version. So you don't have to come into the office. That's a big time commitment for the patient, and every copay, every visit copay, where you have an implantable device and you can stimulate it at home. And so that's kind of the newer thing. Insurance companies have to get on board with paying for it so that patients aren't out of pocket. But that's kind of where things are going a little bit more with incontinence right now. And that's the overactive bladder incontinence, like urge incontinence.
Last question for you. This has been amazing. What are your thoughts on, do you guys see, for pelvic pain, do you see patients who have pain during intercourse specifically, or?
Yeah, so pain with intercourse, just pain sitting, all sorts of different type of pain disorders. And there's a bladder pain disorder called interstitial cystitis that's not related to the muscles, but it's a bladder pain problem. So we see all sorts of things, and it's up to us to diagnose that correctly.
And then will they continue seeing you for the pain management, or do you give those recommendations to a pain management doctor?
So if it's something I can do in the office, such as bladder installations, where we instill medications into the bladder for that interstitial cystitis, I do those in the office. I also do trigger point injections in the pelvic floor for like a high tone muscle spasm type pain. But I don't do like more advanced pain therapy. And so if what I can do in the office is enough, fabulous. If not, I refer to one of my, pain management colleagues, but I keep the patient. And that's why I love my job so much, is exactly like, I'm kind of like the quarterback, I'll refer out for different things, but I want to make sure that she has a home that she can come back to let me know, hey, that's not working anymore. Hey, we need to pivot, or hey, there's another problem. So I'm kind of like their home base for their pelvic floor.
That's so rare nowadays for people to have that person who they can keep coming back to, even after they try different other options, specialties, because, as we know, as doctors, patients are different, and some treatments may work great for the majority of the population, but not for the patient in front of you. And they feel like something's wrong with them, or the doctor misdiagnosed them, when sometimes it just means, we kind of like have an order that we go by these different therapies, and sometimes we just have to get to the second or third or fourth line med, and that's the right one for you.
Exactly. 100%.
Do you have for patients who have recurrent UTIs, I'm just thinking in the interstitial cystitis realm, any recommendations? Like I've heard a lot about vaginal estrogen these days, that, that makes a big difference for some women.
I am all about the vaginal estrogen. As soon as you go through menopause, I feel like every patient, every woman should be on vaginal estrogen. And it's a very low dose, only 2 to 3 nights a week, depending on how your physician orders it. And it does not go into the bloodstream. So that's the important part, is that it does not increase your risk of breast cancer or cardiovascular issues related to hormones, as it would if you took it by patch or by pill. It's very safe and just goes to the pelvic floor. And vaginal atrophy has a whole host of issues, in pelvic floor health. And so once we lose the estrogen in the vagina, you increase your risk of UTIs because of the acidity level that has changed. And so now bacteria can live there where they previously didn't. And also you have receptors of estrogen in the bladder. And so you are more prone to have an overactive bladder, that urgency frequency with that lack of estrogen. So really, estrogen for all. Like, it should just be an automatic thing. You go through menopause, check, here's your estrogen.
Does the vaginal estrogen get to the bladder?
It does, absorbs locally.
Oh, wow.
Yeah.
So, there's one discussion that women have after menopause about, should I be on systemic estrogen, the patch, the pill, like you said, for hot flashes and symptoms like that. But in your mind, even aside from that discussion, whether or not someone should be, the local estrogen, you think is the risk benefit is even more in favor of?
100%. Unless you have some abnormal vaginal bleeding or uterine, malignancy like cancer or a precancer, those you shouldn't be on that, because it is topically, like, locally absorbed. But other than that, majority of women, it's very safe and very beneficial to be on a vaginal cream, a vaginal estrogen cream.
Are there any downsides you can think of to consider for women about the vaginal estrogen after menopause?
So it does increase your discharge. And so a lot of ladies, they forget that a little bit of vaginal discharge is normal in your 20s and 30s. And so, you get into your 50s and 60s and you forget. So it does give you back that vaginal health that you had back in your 30s. And so you do have a little bit of discharge that some women complain about. But other than that, majority of women find that it's really helpful. It helps with painful intercourse due to the atrophy. And it's very low risk in general.
That's great. Well, I'm glad we got to get into that topic too. And you're really just, I can tell, not just a wealth of information, but you really care about, the patients who you're treating. And like you said, being their quarterback, the person who they can count on. So thank you for doing what you do.
Absolutely. Thank you. Thanks for having a platform for other women to learn about what I do.